You've got a patient with head trauma or a thunderclap headache. You open the CT and now the first question is there a bleeding? And if yes, what kind? This is an intraparenchymal hemorrhage. On CT, it appears as a bright hyperdense mass inside the brain parenchyma. Often, there's surrounding dark edema and sometimes a fluid level if the bleed is active. The main causes: hypertension, especially in the basal ganglia, thalamus and cerebellum, amyloid angiopathy in elderly, and anticoagulation. The second one is a subdural hematoma. This is a classic crescent-shaped collection hugging the brain hemisphere. This crosses the suture and it results from a tearing of the bridging veins, often after rotational trauma. On CT, acute subdurals are bright, subacute becomes isodense, and chronic turns dark. In older patients with atrophy, subdural hematomas can expand silently until they are huge, so that's why they're so dangerous. Third is an epidural hematoma. This is a lens shape or biconvex. It's confined by the sutures. It classically results from a temporal bone fracture lacerating the middle meningeal artery. On CT, it's a bright extraaxial mass. The pearl is that about half of the patient have a lucid interval, so they wake up, they seem fine, and then they crash as the hematoma expands. The fourth one is subarachnoidal hemorrhage. On CT, you'll see bright hyperdensity, filling the sulci, cisterns, and fissures. In trauma, it often overlies the convexities. In aneurysm rupture, it centers around the basal cisterns, especially the suprasellar and the sylvian fissures. The main complications are vasospasm, hydrocephalus, and rebleeding. So in trauma or suspected bleed, always start with a non-contrast CT. Shape and location will tell you the type. And don't forget to check the mass effect, shift, or herniation. Those kill faster than the hemorrhage itself.